जब भी ऐसे छोटा अननेसेसरी हो जाता है ना, जैसे आप याद रखिए यहाँ से सेकंड बटन डुप्लीकेट, देन हो जाएगा। कंट्रोल एल फॉर लेजर। ये आप आई रेकमेंड ये लेक्चर में आप सिर्फ लेजर यूज करें, आउटलाइन मत कीजिए। अगर आपको जरूरत पड़ी तो मैं बैठा हूँ।
ठीक है,
ठीक है, स्टार्ट कर दो। कैमरा भी है, शैडो वगैरह सब देखो। कर दो, जा सकते हो।
स्टार्ट।
1 सेकंड।
Hello everyone, I am Dr. Josefa Runderawala, consultant gastroenterologist and hepatologist. We'll be starting with the gastroenterology series of lectures, and in this series we'll be beginning with the symptomatology. The first symptom we'll be dealing with is approach to dysphagia. So the most important thing is the definition of dysphagia. So the word dysphagia is derived from the Greek word phagia, which means to eat.
पॉइंट कीजिए लेजर से, वापस स्टार्ट करते हैं।
ओके,
The
अच्छा,
most important.
तो किससे करूँ? इससे?
हाँ, बेटर इजी रहेगा।
तो नहीं होता है।
टच कीजिए ना।
चला, ओके, ऐसा?
यस, 1 सेकंड।
So the word dysphagia is derived from the Greek word phagia, which means to eat, and dys means with difficulty. So it specifically refers to the sensation of food being hindered in its normal passage from the mouth to the stomach. So this is the definition of dysphagia. There are few other terminologies which you should be aware of. The one thing is aphagia.
ऐसा पॉपअप आ जाता है तो you just press escape and start again. वो sentence.
So there are other terminologies such as aphagia, odynophagia, and globus pharyngeus. So these are the 3 important terminologies we should be aware of. Aphagia means complete obstruction to the swallowing. Odynophagia means there is difficulty.
One more thing, I'll stop. Next time से ना आप ये slide में include.
So that's what I was thinking that I will write down this.
Okay, you can write. I enabled pen for you.
Okay. So there were 3 other terminologies which you should be aware of. First is aphagia. Second is odynophagia.
I don't think we should write. Just a second, मैं एक next slide में ये डाल देता हूँ। कौन से words हैं?
Okay.
आप इधर लिख दीजिए, मैं वहाँ से रेफर करके ऐड करता हूँ। लिख दीजिए। कुछ स्पेलिंग मिस्टेक है। टाइप्स ऑफ क्या है?
These are terminologies.
Okay. Okay. Is there anything you want else?
No,
after this?
No, it's fine.
डायरेक्ट इधर जाए तो
Yes,
चलेगा?
yes.
ठीक है। अपन I think you should start with definition again.
I'll start with again. The whole thing I will start.
Okay, no
Okay?
problem. Just a second.
Yeah.
Yes.
So we'll be discussing about the dysphagia, approach to dysphagia. The word dysphagia is derived from the Greek word phagia, which means to eat, and the dis which means
वापस स्टार्ट करना पड़ेगा. Yes.
it is not full screen.
फुल स्क्रीन नहीं है.
नहीं.
अच्छा, जब भी ऐसा हो
Hmm.
तो यहाँ से सेकंड ऑप्शन.
Okay. So the word dysphagia is derived.
सॉरी.
Not done yet.
नहीं हो. एक बार चेक कीजिए.
नहीं.
कंट्रोल पी कर सकते हो. यस. नहीं, पी से तो पेन होता है. कंट्रोल एल.
Yes. Yes.
नेक्स्ट स्लाइड पे जाइए. ये इंक आपने ड्रॉ किया ना, ई फॉर इरेजर, जस्ट ई, नॉट कंट्रोल.
The word dysphagia is derived from the Greek word phagia, which means to eat, and dys means with difficulty. It specifically refers to the sensation of food being hindered in its normal passage from mouth to the stomach. So there are other various terminologies we should be aware of, including with the dysphagia. The first is aphagia, which means complete obstruction of the food into the esophagus. Second terminology is odynophagia, which means there is a difficulty while swallowing, and pain while swallowing is the main definition of odynophagia. And the third is the globus pharyngeus, in which there is a sensation of something sticking in the throat. So these are the three other terminologies which you should be aware of along with dysphagia. Before going for a dysphagia, we should know what is the normal swallowing. So the normal deglutition is a smooth, coordinated process that involves a complex series of voluntary and involuntary neuromuscular contraction, and typically is divided into three distinct phases. The first one is oral phase, the second one is a pharyngeal phase, and third one is a esophageal phase. So in this diagram we can see is as the oral phase is voluntary phase, that means is a preparatory phase. Second phase is a pharyngeal phase, which is involuntary deglutition reflex, which is centrally mediated. There are multiple neurons which is causing this thing. Third is the esophageal phase, which is deglutition inhibition and peristalsis. So we will go in detail of each of these phases. The first one is the oral phase. So you can see in oral phase, the preparatory phase, which is very important. When you eat food, the food is first masticated and it mixed with the saliva. And the process begins with the contraction of the tongue and the striated muscles of the mastication. And in this oral phase, a formed bolus is positioned in the middle of the tongue, and the bolus is then pressed firmly against the tonsillar pillar, triggering to the pharyngeal phase. That means the food is prepared to be swallowed inside the esophagus. So this is called the oral phase. In short, the whatever food we eat, it is formed into bolus, it is being mixed and is mixed with the saliva and is be ready to be pushed down into your esophagus. But before that, there is something other phase called pharyngeal phase. What happens in the pharyngeal phase? It propels through the pharynx into the esophagus, preventing air entry into the airway. That means when you eat food, the food bolus is formed and it has to be gulped down into the esophagus, preventing its entry into the trachea. That means it's a complicated process. It's a centrally mediated process, neuronally mediated process. So what happens in this? There are multiple neurons are getting involved, in which the food is being pushed down into the esophagus, closing the windpipe so that it does not get aspirated into trachea, and the normal swelling process follows. So the superior constrictor muscle contracts, beginning the pharyngeal peristalsis, while tongue base drives the bolus posteriorly. So in the oral phase, when the food bolus has been prepared, which needs to be pushed down into the esophagus through the pharynx. So in that case, the tongue which is there, which is an important organ, which moves your bolus posteriorly. Then what happens? The respiration ceases. That means for momentarily you stop breathing during expiration, and the larynx is elevated and pulled forward, which facilitates the UES. What do you mean by UES? It's upper esophageal sphincter. That means this is the sphincter which is generally closed, but when the food enters into it, it opens so that food can enter into a esophagus and then into the stomach. So this is a very important phase, pharyngeal phase. We'll further see how in dysphagia this is getting affected. And the last phase is the esophageal phase. So the length of the esophagus is generally around 25 centimeter. The range is from 18 to 25 centimeter. So this bolus is to be propelled about 25 centimeter from the cricopharyngeal through the thoracic esophagus via the peristaltic contraction. That means the food bolus which has been prepared through oral phase, which has moved through the pharyngeal phase into the UES. Now it has to be traveled through the esophagus to come into the stomach. And the lower esophageal sphincter relaxes. So what happens once the food arrives at the lower esophageal sphincter, which is located at the junction of esophagus and the stomach, it relaxes so that the food bolus get entered into a stomach. So this is a normal deglutition process in the human body. So so why we are talking about this as a process? Because we are dealing with dysphagia, which is difficulty in swallowing. So before that, we should understand what is the normal swallowing process, and then only we will be able to understand the diseased one. So coming to the classification of dysphagia, it is broadly been classified into two types: oropharyngeal dysphagia and esophageal dysphagia. As the name suggests, we say oropharyngeal. That means, as we have discussed in the previous slides, that these are the two phases, oral phases and pharyngeal phases. So that means there would be a involvement of the two phases, or there will be a disease which will be affecting these two phases, and that will be causing a oropharyngeal dysphagia. And the second cause is esophageal dysphagia. That means in this condition the esophageal phase would be involved. So what do you mean by oropharyngeal dysphagia? Is produced by the abnormalities affecting the finely tuned neuromuscular mechanism of the striated muscle of the mouth, pharynx and UES, which is the upper esophageal sphincter. As we have seen in the previous slide, as I explained you that the pharyngeal phase is a very important phase and is neuromuscularly coordinated. There are multiple complex systems which is being involved. So therefore, this dysphagia is caused by the disease which affects the oral phase or a pharyngeal phase. And what do you mean by esophageal dysphagia? It is caused by the variety of the disorders affecting the smooth muscle of the esophagus. Before this, I want to explain you something more, that in esophagus, the muscle is being divided in two parts. The upper one third is the striated muscle. That means it's under the voluntary contraction, and the lower two third is the smooth muscle, which is involuntary. So the in smooth muscle of the esophagus is getting affected, you will have esophageal dysphagia. While the voluntary striated muscle is getting affected, then you have a oropharyngeal dysphagia. Now, what is the pathophysiology behind this kind of dysphagia? So a problem with the strength or the coordination of the muscle required to move a material, that is the bolus of the food, from the mouth to the stomach. So that means your muscles of the oral muscles or the pharyngeal muscles are getting affected. It will cause this oropharyngeal dysphagia. Or there could be a fixed obstruction somewhere between the mouth and the stomach. That means there is some obstruction which is hindering the passage of the food from the mouth to the stomach, or there may be sometime a combination of both of these. So it's not exclusive that it could be either one or two. It can be a combination of both. Now, what are the different mechanisms of dysphagia? So up till now we have learned the definition of dysphagia, the types of dysphagia, normal swallowing process. Now we need to understand, on the basis of the normal swallowing process, what is the mechanisms of dysphagia. So if there is a peristaltic orderly contraction fails to develop or progress, that means if the food bolus is formed which is difficult, or there is a disorderly contraction, it will not be able to progress through the pharynx into the esophagus. So the accumulated bolus of the food distends the esophageal lumen and causes a discomfort that is associated with dysphagia. In some patients, like elderly, dysphagia is a result of low amplitude primary or secondary peristaltic activity that is insufficient to clear the esophagus. And other patients have a primary or secondary motility disorder. That means that grossly disturbs the orderly contraction of the esophageal body. As I explained you, that this is a centrally mediated process in which each step is very important. If there is some dysregulation in it, it will cause the dysphagia. So because these motor abnormalities may not be present with every swallow, dysphagia may wax and wane. That means it could be an intermittent kind of dysphagia. And definitely the last cause will be mechanical narrowing. That means the lumen of the esophagus has been narrowed, which will hinder the swallowing process and the transfer of food bolus from the mouth to the stomach. Now, can we localize what kind of dysphagia it is? So definitely. So there is some soft signals or surrogate markers. So dysphagia localized to the throat and above sternal notch mostly points to the oropharyngeal dysphagia. So that means if the oral phase or pharyngeal phase is affected, so there will be a pain or dysphagia would be localized to either the throat or the above sternal notch. So that will point, and 30% of the esophageal dysphagia is referred proximally. Dysphagia localized to the chest or epigastric is esophageal in origin. As we know, the oral and pharyngeal phase is mostly involved in the oral and pharynx, and esophagus is involved in the esophageal phase. So we can easily localize whether the dysphagia is of oropharyngeal type or is a esophageal type. Now we will be going in detail of the oropharyngeal dysphagia, which is first type. So this is a process that affects the mouth, hypopharynx, and upper esophagus, producing a distinct type of dysphagia. It is inability to initiate the act of swallowing. As I mentioned, in swallowing, there are three basic phases. The first is oral phase, which is a preparatory phase. So when that phase is affected, it cannot initiate the act of swallowing. That means the patient is not able to form a bolus and not able to start swallowing from the oral phase to pharynx. That is also called a transfer dysphagia. That means what happens? A transfer dysphagia is impaired ability of the to transfer food successfully from the hypopharyngeal area through the UES into the esophageal body. That means when we are transferring the food bolus from the pharynx to the esophagus, the patient who is not able to do that, that is called transfer dysphagia. So what are the important clinical features of this oropharyngeal dysphagia? So the patient will complain of food sticking in the throat. That means he is starting to swallow, but the food is getting choked up in the throat. There will be difficulty initiating a swallow. He will not able to swallow it because swallowing is a complex coordinated process, so the nerves and muscle has to be coordinated completely. If the person who is having a neurological issues, he will not be able to swallow this thing. The third is nasal regurgitation. That means in a pharyngeal phase, as I mentioned, that your larynx should be covered up. That means it should be stopping the food to be entering into the trachea. So as there is a oropharyngeal dysphagia, a patient might have a nasal regurgitation. Since the food particle enters into the trachea, he may cough or it may choke during the swallowing. He will have a drooling of saliva because this is an oropharyngeal phase. It requires a mastication. Okay, it requires a preparatory phase with the saliva. If there is an issue with the salivation, there will be drooling of the saliva, and as the patient is not able to pass the food into the esophagus, there would be associated with aspiration in trachea. As I said, that a larynx has to be covered up and the trachea has to be covered up while the esophagus is opened up. Okay, so in that case, if there is a difficulty in the coordination, there would be aspiration into trachea. There would be a hoarseness of voice if there is recurrent laryngeal nerve is getting affected. In such cases, there could be a hoarseness of the voice. There could be unexplained weight loss and other neurological findings we can see, as this is a more of a neuromuscular dysphagia. So which are the diseases which is causing this oropharyngeal dysphagia? So the concept of this you will be able to understand if you have understood the previous slides, in which I have mentioned that oral phase and the pharyngeal phase is a neuromuscularly coordinated, is a complex mechanism. So the diseases of the central nervous system will be causing, or the neuromuscular disease will be causing a oropharyngeal dysphagia. So there are multiple diseases of which CNS origin would be a cerebrovascular accident. That means a patient who has a stroke, infarct, hemorrhage, they will have a difficulty in swallowing as their swallowing process has been affected. A Parkinson's disease, they have a brainstem involvement. Wilson's disease, which is also a neurological issue. Multiple sclerosis, amyotrophic lateral sclerosis, brainstem tumors. Why brainstem tumors? Because the reflex is on the brainstem. It causes a difficulty in initiating the swallowing or difficulty in transferring the bolus of food from the pharynx to the stomach. So even the brainstem tumors can cause oropharyngeal dysphagia. Tabes dorsalis, that means it's a kind of a syphilis. Even that can cause, when in which a neurological involvement is there, it can cause a oropharyngeal dysphagia. The peripheral nervous systems like bulbar poliomyelitis and peripheral neuropathy. Examples are diphtheria, botulism, rabies, or diabetes mellitus. These all affect the nervous system, and hence it can have a difficulty in swallowing and causing oropharyngeal dysphagia. Motor end plate myasthenia gravis, which is an important disease which affects your muscles, NM junction, neuromuscular junction. It also can cause a oropharyngeal dysphagia. As all these diseases, you can understand these are all neuromuscular diseases because the oral and the pharynx requires a good coordination of the brain and the larynx and pharynx. Muscles like muscular dystrophies, primary myositis, amyloidosis, SLE. These are all exhaustive list of the diseases which causes oropharyngeal dysphagia. There are some other local inflammatory structural lesions like pharyngitis, abscesses, tuberculosis, syphilis. So these are all local structural causes. Okay, if the patient who is having a tonsillar abscess, he has a pharyngitis, even in such cases they will be having difficulty in difficulty in swallowing, also called dysphagia. But important in this would be a odynophagia. Why odynophagia? What is the definition of odynophagia? The pain while swallowing. So as these are local inflammatory processes, there would be a pain while swallowing. So in such patients, there would be, along with dysphagia, there would be odynophagia. Also a neoplasm, head and neck cancer, congenital webs, all these can cause a local causes which can result into a your oropharyngeal dysphagia. Plummer-Vincent syndrome, which is very important syndrome, it is seen in the young females, is a triad of iron deficiency, cervical webs, and dysphagia. So this causes a also causes a oropharyngeal dysphagia. As there is a cervical web, that means there is a web, there is an obstruction in the upper esophageal sphincter area, which causes a difficulty in swallowing. Then the extrinsic compression, such as thyromegaly. If the patient who has a large thyroid, which will cause a compression of the trachea and the esophagus, will be difficulty in swallowing. Cervical spine hyperostosis. That means from posteriorly, if the cervical spine hyperostosis causes, it causes a compression of the esophagus and will lead to a dysphagia. Lymphadenopathy, that means enlarged lymph nodes around the esophagus will cause a compression of the esophagus and result into a dysphagia. Or a surgical resection of oropharynx. If there is some surgeries has been done from the neoplastic disease, it can result into a oropharyngeal dysphagia. Other disorders of UES, that means abnormal US relaxation or opening. As I told you that in the pharyngeal phase, the bolus of the food has to be transferred from the pharynx through the UES into the esophagus. So if there is a abnormality in the UES opening, it will also result into a dysphagia. That means incomplete relaxation causing a cricopharyngeal achalasia or a central nervous system lymphoma or oculopharyngeal muscular dystrophy. These are rare causes which can result into a abnormal UES opening. Second is inadequate opening. Even though there is no structural issue, but there is an inadequate opening because of cricopharyngeal bar or Zenker diverticulum, patient will have a oropharyngeal dysphagia. Or there could be a delayed relaxation. That means in the rare cases of familial dysautonomia. Now coming to the second part of the dysphagia, which is the esophageal dysphagia. It will involve the third step, the third phase of deglutition, which is the esophageal phase. So three important questions are particularly crucial in this esophageal dysphagia. What is it? The first is what kind of food produces the symptom. So there could be a liquid food or a solid food or both. What causes the symptom? This has to be asked to the patient. Second is the dysphagia intermittent or progressive? That means the dysphagia which is patient is suffering, is it intermittently it's coming, that is today it's there, tomorrow is not there, then again day after tomorrow there is a dysphagia, or is it progressive? That means that initially it was for a milder symptoms and progressively it has been progressed for a severe diseases. Or third is it associated with heartburn? So all these three questions will guide you towards the cause of esophageal dysphagia. And physical examination is usually not revealing in patient with esophageal dysphagia. Why? Because this is the inner disease of the esophagus, or we can just say the lower third of the esophagus, where the smooth muscle has been affected. In the oral and pharyngeal phase, we can have multiple signs of physical symptoms because the oral and the mouth and the pharynx are getting involved. But in this case, the esophagus is involved, so you may not have that many physical signs, except in the condition of scleroderma. Why? Because scleroderma is a systemic disease. So you have other manifestation of the scleroderma which may point towards the esophageal dysphagia. And esophageal dysphagia is frequently can be relieved by various maneuvers. So what happens, the patient who suffers from this esophageal dysphagia, they will have a choking sensation in their chest or in the epigastric region, and they will feel that the food is getting obstructed. So by doing some maneuvers, they can relax the esophagus and the food can pass into the stomach. What are these maneuvers? Is like repeated swallowing. So what happens once the patient's food bolus is impacted, they will try to do a repeated swallowing which may open the esophagus and the food may pass through, or they may do a raising the arms over the head. So once these are the habits which the esophageal dysphagia patient do, because they feel a choking sensation, though they try to raise their arms or they throw their shoulders back, so that it causes the relaxation of the esophageal muscle and pushes the food bolus into the stomach. Now coming to the progression of the esophageal dysphagia. So if it would be static dysphagia, that means the patient does not have the progression of the dysphagia. It is the same from the day 1 till now. That means the motility disorder is there. What do you mean by motility disorder? That means the patient's muscle has been involved, and there is no structural issue, not structural disease which is there in the esophagus, but there is a issue with the muscles of the esophagus, and which is causing a disorganized peristalsis, which is leading to a static dysphagia or a motility disorder. And then the next is a progressive dysphagia. That means there is a structural disorder associated with obstruction. So what happens? Giving an example, suppose if the patient has a structural disorder like a cancer or an esophageal neoplasm. Initially, the neoplasm is a small growth, so they may have a difficulty in only solid food. But however, as the disease progresses, as the obstruction becomes more severe, they also have a difficulty in taking liquids. So that means it's a progression. Initially, they could have a solid only obstruction with solid food, then semi-solid food, and then also liquid. That means the disease has been progressing. This is leading. This is the classification based on the progression. Now the next type of, on the basis of which we can differentiate the esophageal dysphagia, is a type of food intake. So if it's only for solid food, it's a structural. As I mentioned, in structure, because solid food is solid, so it will require more lumen to pass into the esophagus. So if there is a small lesion, it will cause a obstruction to the solid food. But as the lesion will progress, it may also cause a difficulty in liquid swallowing. But in a motor disorder, as in motility, as the muscles are involved, it will have a swallowing difficulty from the beginning for both liquid as well as solid. So both solids and liquid would be related to a motor disorder. And the other type of dysphagia is intermittent. As I mentioned, intermittent means these are not progressive. It could be related to Schwarzschild ring, which is a kind of ring which causes obstruction intermittently, or it could be eosinophilic esophagitis. This is a kind of eosinophilic disorder which causes intermittent dysphagia. So what are the associated symptoms because of this esophageal dysphagia? There is something called odynophagia. As I mentioned, what do you mean odynophagia? The pain while swallowing. So what are the causes which can cause this odynophagia? One thing is a pill-induced esophagitis. What do you mean by pill-induced esophagitis? That means a person who takes a pill and does not take adequate water along with the pill. There are certain drugs like doxycycline, iron tablets, which needs to be gulped down with a full glass of water. If it's not gulped down with a full glass of water, it might get stuck into the esophagus and may cause a local ulcer, which can lead to a dysphagia or odynophagia. Infectious esophagitis. The diseases like candida or herpes, fungal infection or viral infection or CMV, all these kind of CMV esophagitis or herpetic esophagitis, they can cause the odynophagia because these are painful conditions. So whenever patients eat or drink something, they will have pain along with dysphagia. A caustic injury, that means a patient who has accidentally or intentionally has taken a corrosive injury. It can lead to a esophageal injury, then might have odynophagia along with dysphagia. Chemotherapy mucositis. This is also important cause. As the cases of cancers are increasing and also the chemotherapy based regimens are increasing, the patient might suffer from chemotherapy mucositis, which is a side effects of the chemotherapeutic drug. Heartburn. If there is a heartburn, that means the patient suffers from GERD, which is gastroesophageal reflux disease. And the patient who suffers from a long-standing GERD, so they will have heartburn, and subsequently they developed up something called peptic stricture. Stricture means what? Narrowing, and peptic means related to the acid. So because of this peptic stricture, there will be a narrowing of the esophagus and they develop dysphagia. History suggestive of atopy. As I mentioned, the eosinophilic esophagitis is a disease which is related to the eosinophils, and as you know, eosinophils are been the cells which is there in allergy and atopy. The person who has asthma or some atopic allergy, they might have the disease called eosinophilic esophagitis, and they develop a dysphagia. Thyromegaly. So as I mentioned, if there is an enlargement of thyroid or a goiter, there will be compression of the esophagus, and that will lead to a dysphagia. Skin tightening, scleroderma. As I mentioned, explained you previously, that these are the signs of the scleroderma. And bullous lesion, so bullous pemphigoid. As the lesions are there on the skin, there will be also a lesion in the esophageal mucosa, which will lead to a dysphagia. Now, as we learned about the etiologies of the oropharyngeal dysphagia, now we will learn about the etiologies of esophageal dysphagia. So what are the etiologies of esophageal dysphagia? The first is the neuromuscular disorders like motility disorder. The most common is the achalasia, in which the muscle of the esophagus are getting involved. So there is no structural lesion, but there is the muscles which are getting involved. So this is called a motor dysphagia. So what are the characteristics of this? There will be a dysphagia to both solids and liquid from the beginning, and these are non-progressive dysphagia. So what are the causes? Achalasia, scleroderma, and diffuse esophageal spasm. And there are some other rare causes of the mortality such as nutcracker esophagus, hypertensive LES, vigorous achalasia, or non-specific esophageal dysmotility, and other secondary motility disorders such as Chagas disease.
वो repeat कर दीजिए.
So there are some other secondary motility disorders such as Chagas disease. So Chagas disease is an infectious disease which is caused by a redovid bug in which the ganglions of the esophagus are getting involved and may lead to a motility disorder. Now coming to the other part, the second part of esophageal dysphagia. The first is the motor, which we have already explained. Now coming to mechanical dysphagia.
और pointer move नहीं हो रहा है. अच्छा.
So the second is a mechanical dysphagia, which is a progressive dysphagia, and it will begin with the solid food as the lumen is narrowed partially. But as the disease progresses, it also will have a dysphagia to liquids. So what are the diseases which are most common? Is a peptic stricture. As I mentioned, if the long-standing heartburn, long-standing GERD may cause a stricture into the esophagus, lower esophagus will result into dysphagia. Lower esophagus Ketzgering, but the important differential point over here is that they will have intermittent dysphagia. And carcinoma. So carcinoma, as I explained you before, initially the lesion will be a smaller, so there will be a only obstruction to the solid, but as the disease will progress, it will lead into solid as well as liquid dysphagia. And what are the other causes? It will be esophageal webs, esophageal diverticula, benign tumors such as leiomyoma or lipoma, and foreign bodies, mostly seen in children. So children suddenly takes some foreign body into the esophagus, and that lead to an acute obstruction and lead to a dysphagia. Or elderly patient, when they have a difficulty or they have a dementia or they have Parkinson's disease, they have difficulty in coordination, they can have a foreign body in their esophagus, which is leading to a mechanical dysphagia. Also, the other causes will be a vascular compression, mediastinal abnormalities, or cervical osteoarthritis. These are external causes. These are not from the intraluminal. These are extraluminal from the esophagus, causing a esophageal dysphagia. So this is a very good flow chart in which you can understand how we should approach the dysphagia. So this is dysphagia. First, we'll decide about whether there is a difficulty initiating swallowing or food stop or sticks after swallowed. So as we have seen, if there is initiating swallowing or the patient also has symptoms like coughing, choking, and nasal regurgitation, that means the oral and the pharyngeal phase is involved, and it's called oropharyngeal dysphagia. And the disease which we have seen, we have to rule out the other neuromuscular causes. But if the food stops or sticks after swallowed, that means the patient is suffering from esophageal dysphagia. And in esophageal dysphagia, whether it's only solid or both solid or liquid. As I mentioned from the beginning, if it's both for solid or liquid, it will be neuromuscular disorder or a motor disorder, in which it could be either intermittent or progressive. If it's intermittent, it may cause chest pain, causing diffuse esophageal spasm. And if it's progressive, as a chronic heartburn, then a scleroderma. If it's a bland regurgitation with weight loss, it's achalasia. So this is the flow chart for esophageal dysphagia in a motor dysphagia. But if it's only solid food, as I mentioned, initially it will be with only solid, but subsequently it might develop into a solid and liquid. So this is because of mechanical obstruction. And if it's intermittent, so it could be a lower esophageal ring or a Ketzgering. If it's a progressive and they have a chronic heartburn, but there's no weight loss, then a peptic stricture. But if it's age is elderly more than 50, but now the age has been coming down to less than 45, and they have a significant weight loss, then it will lead to a carcinoma. So this is a flowchart for solid food dysphagia, in which there is mechanical obstruction. So in short, dysphagia, oropharyngeal dysphagia, and mechanical dysphagia or esophageal dysphagia, and in esophageal dysphagia again in motility, a neuromuscular disorder, or a mechanical obstruction. Now, what we will see in the clinical examination. So if this patient comes to your clinic or comes to your OPD, what are the clinical examination which is important in such patients? The patient who complains of dysphagia along with odynophagia plus or minus. So first you need to see inspection of oral cavity to understand whether this is oropharyngeal dysphagia, dentition, oropharynx. So these are all for your oropharyngeal phase, oral and the pharynx. Indirect laryngoscopy, cranial nerve examination, because is any your neuromuscular disease has been affecting the nerves, so the tongue, gag, and cough reflex has to be seen. Is there hoarseness or a vocal cord mobility? And then you need to see a neck for lymph node, neck masses, thyroid enlargement, changes in skin. So if you know the causes of the dysphagia, you will be able to understand the full complete clinical examination. So these are the various points which needs to be seen for your patient who is walking into your OPD for dysphagia. And then coming to this, the clinical examination has been done. Now coming to the investigation. So what investigation you will order? You cannot order all the investigation in the world. So you need to be thorough about the differential diagnosis and then going. So the previously which I explained you about the dysphagia this thing flow chart, that will be able to differentiate into what kind of dysphagia person is suffering, and will guide towards what kind of investigation you should order. So the CBC, ESR or C-reactive protein, LFT, RFT along with serum calcium, and thyroid function test. These are the must in a patient who comes to your clinic for your dysphagia. And then for these are the special tests for diagnosis. This was initially just for the routine screening. Now these are special tests for diagnosis. Chest X-ray is very important to understand any mediastinal mass or thyroid or any enlargement. Barium studies needs to be done, in which we will be able to understand localized strictures, diverticula or any herniation such as hiatus hernia. Fluoroscopy is swallow study. That means we'll be able to understand oral or pharyngeal dysphagia, in which the patient gulps down the thick barium meal or barium swallow, and we're able to see under fluoroscopy, under X-ray, is there any disease, is there any problem with the oral phase or pharyngeal phase. Then comes endoscopy, which is a gold standard, in which we'll be able to confirm the diagnosis. We can take a biopsy as required, and we can do therapeutic interventions, such as if there is a strictures or such as there is a stricture or carcinoma, in which in case we might take a biopsy, or we might put a metal stent, or we might dilate with the balloon so that the patient is relieved from the dysphagia. CT scanning, if the patient is suffering from malignancy, might need to see if the disease has been spread to some other region. Endoscopic ultrasound, this is a new modality which has been there in our armamentarium, in which we will be able to understand if the lesion is there in the muscle or outside the muscle, outside the esophagus, or it's in the mucosa. Esophageal manometry and esophageal pH study, these are for the motor disorder as well as for the reflux diseases. We might need to understand. These are the special tests which are not available everywhere, and we'll be able to understand what kind of disease the patient is suffering from. Coming to the treatment. So as I mentioned, in oropharyngeal dysphagia, the disease is basically, the disorder is basically related to a neuromuscular this thing. So there will not be a treatment for localized thing. It has to be a neurological or a muscular treatment, or the treatment of the underlying disease that may help in the patient for the treatment. So it's been written that for oropharyngeal dysphagia, a modification of dietary consistency, swallowing maneuvers to minimize aspiration, exercise to strengthen the pharyngeal muscle. Why? Because the pharyngeal muscles are weak. There is a neurological issue. So they are not able to transfer that bolus into the esophagus and causing dysphagia. So in such patient, we might need to go for a training of their pharyngeal muscles. Swallowing reflex has to be developed. Speech therapy, swallowing therapy has to be done. Or could be a considered alternative thing, something like PEG, which is percutaneous gastrostomy tube, other route for the feeding. That means that directly a pipe or a tube has been placed in the stomach so that the feeding can be done. Or we need to understand, or we need to improve the treatment of the underlying disease, the Parkinson's disease. The dose has to be optimized, or some other therapy for Parkinson's disease has to be given. Myasthenia gravis, the treatment of the myasthenia gravis has to be done to relieve from the neuromuscular coordination which is there in the pharynx, to improve the swallowing thing. Now coming to the esophageal dysphagia, benign strictures and rings can be treated endoscopy with dilatation. As I mentioned before, it can be dilated with the balloon and can help in the relieving of the dysphagia. Peptic stricture should also be treated with proton pump inhibitor. As the cause of this peptic stricture is basically a reflux, the gastric acid has been refluxed into a esophagus, so this has to be treated with a proton pump inhibitor or S2RA blockers. If the patient who is suffering from achalasia, so what is achalasia? Achalasia is a primary motor disorder of the esophageal dysphagia, and it is a special kind of disease in which the muscles get weak, and there will be a permanent contraction of the LES which needs to be relieved. So there is something called POEM, which is per oral endoscopic myotomy versus surgical, this is Heller's myotomy, versus endoscopic balloon dilatation can be done. While botulinum toxin injection can be done temporarily, but it has a treatment, the treatment just lasts for around 2 to 3 months, and a repeated botulinum toxin has to be given. Malignancy could be extrinsic versus intrinsic compression. So if the malignancy is amenable to surgery, the patient should undergo surgery plus chemoradiotherapy depending on the kind of malignancy patient is suffering from. And if there is some Zenker's diverticulum or cervical osteophytes, then depending on that, a surgery has to be done. Thank you very much. I hope you have enjoyed my lecture and would gather some good points for your helping you in your private practice. Thank you.